Oh, yes, we're recording. Okay. Now I share. Okay, what happened there? Oh, I shared the wrong one, didn't I? Okay, dang it. I have two ready to go today. I shared the wrong one. There we are. That looks better. So let me see. We went through ADHD. Huzzah! Thank you. We went through this one. Quite a few questions on this. Yes, here we are. So specific learning disorders. I think we left it here. And it's, says pretty clearly inability to achieve a designated area of learning consistent with one's person's overall intellectual functioning. So what this means is they're not intellectually disabled. They just have a particular learning disorder. So dyslexia for reading and dyscalculia for mathematics, like calculus, calculating. So dyscalculia for mathematics. And that's something we don't screen for, I don't think, as much as we probably could. This has been a conversation I've had with our disability people and mathematics teachers that we want to. Because a lot of students will say that they're, and this is what everybody pretty much says, that they're bad at math. Bad at math. First off, it's kind of an interesting thing. If you stop saying that, if you say that, well, I struggle with math, but I think I can learn it, people get better at math. So it's basically, it's kind of a self-fulfilling prophecy if you say you're bad at math. That said, there are measures for dyscalculia, and we might, if we find a student has that, we might want to modify things accordingly. It's the same kind of as dyslexia. They'll switch things back and forth, get letters mixed up. This will get numbers mixed up. Language disorder. They get this out of the way. It's kind of right in my way. Various persistent problems with language. This includes speech sound disorder. So articulation. This is pretty common, actually. As a matter of fact, my family has a kind of a history of it. They have a hard times with the Oz. My sister has that, and yeah, so it's actually they tend to run through families. Actually, they're genetic and based. So it's my sister and my niece, her daughter, both have some articulation, speech sound disorders. So fluency, voice production, they're just not able to talk, basically. And then childhood onset fluency disorder is stuttering. People have a hard time saying words. They've got have a hard time getting them out. And make sure keeping along lines here with everybody. So that's the idea. They'll have a harder time speaking their words, harder time. Let's see. I don't think I'm going to follow this along here. Yeah, communication disorder. So on speaking, so pauses within a word. Here we are looking for silent or blocking, filled and unfilled pauses in speech, injections like that kind of idea, and struggling to reserve speaking. Again, it's relatively common, and it can be embarrassing for folks because it's long lasting. But that all said, people generally can work around it. I'm not getting my little thing set up there. There we go. Thank you. And then pragmatic communication disorder. This is one of the symptoms. I think we talked about how it kind of goes through a lot of disorders, just sort of awkward socially. And so they just have a hard time in pragmatics. They don't know. Pragmatics is the idea that you have a certain way of talking in a certain situation. Okay, so here in a classroom, there's sort of one way of talking. I tend to not talk this way when I'm, with my kids. It'd be kind of funny talking to my children and this sort of rhythm and that kind of thing. That's pragmatics. Others will just not quite get that. Just talk. Not very practical, I guess. And motor disorders, tic disorders. Physically awkward. This is developmental coordination disorder. That's the first one here. This is where kids are just kind of clumsy. They can't have a hard time getting dressed, hard time with sports, that kind of idea, games and eating meals. They're just kind of clumsy and awkward. Definitely with sports, it's probably where it comes out sort of the most, I think, in kids, because they just are, sports are kind of important when you're starting off in grade school. People are starting to do this sort of thing, and kids will just be, not very good at it and get teased. It's one of the things is they'll get teased, and that just starts getting into their self-esteem. And then repetitive, driven, apparently purposeless stereotypic movement. So kind of this sort of idea, and it's not in context of autism. That's kind of a major point, that they have the movement disorder over and over and over again, but not does not coordinate with autism. And tics. Tics is one that Jacob has. He has actually Tourette's as motor and vocal tics. So this is just a.
So he has Tourette's?
Oh, I shouldn't have told you that, should I?
Well, I was kind of confused on it earlier when I was going through it last night, but he didn't seem to have any like muscle spasms, or he wouldn't really spat out like words or cuss words or anything like that.
But he goes, he kind of
so
ticks
that's part of Tourette's. I thought that was part of like tic disorder or something, like tics.
You can, but it'd probably be more tic disorder, because that's right. I mean, you can probably argue both of those, but the vocal tics tend to be offensive more with Tourette's, whereas this kind of vocalization is probably just more of a tic disorder. Yeah, I probably would say tic disorder. And so, I would say that I probably more of a tic, because he's not being offensive, right?
Right.
Not being offensive at all. Yeah, so it's more of a tic disorder. Sorry about that. But yeah, motor tics apparently are odd or offensive as well. Flipping you the finger or something like that, I guess, with Tourette's. But it's more of a tic. So you kind of tics and then, that sort of idea is tics. The dopamine nightmare, I think we talked about with Jacob. I think we kind of alluded to that on Tuesday, between the tics and the ADHD.
Yeah, we did.
Okay. I'm giving too much away here. Maybe just being in my office, I feel less professory or something. Yeah.
Well, it kind of helps out because I was kind of stuck on the dopamine nightmare, so it kind of helps put a little bit of light into it, I guess.
Yeah, it does, and I'm joking that I'm saying I'm giving away too much, because that's fine. Yeah, the idea. It's pretty interesting, right? I mean, it's again, got to remember those 4 dopamine pathways. I tell you what, you got to remember those 4 dopamine pathways, because it's once again, this comes into play here, because Tourette's is more the nigrostriatal, so substantia nigra to the stria, the basal ganglia. Basal ganglia, it's unfortunate, because those same structures, the caudate, putamen, and globus pallidus, those 3 structures in that area, they're called both the stria, because they're kind of striped. They're called the basal ganglia, and they're also called the pyramidal systems, because they're shaped like a pyramid. So those 3 terms are for the same structures. Okay, so it gets confusing, because you'll have the nigrostriatal, so that's substantia nigra to the stria, or the basal ganglia. These medications like Haldol and Risperdal, and some of those antipsychotics, they'll have extrapyramidal side effects. So now they're referring it to the pyramidal tracts, but it's the same thing. So it's really unfortunate. I don't know. There's probably some sadistic neuroanatomists out there that decided to name these things 3 different things. But so the pyramidal tracts, the basal ganglia, and the stria are all the same thing, more or less. Globus pallidus, caudate, and putamen. And so sorry about that. It's not my fault, but yeah, that's the thing. So where this gets to be of trouble with the motor disorders, with the tics and the ADHD, because the mesocortical is where the attention is, right? So you want to increase dopamine and norepinephrine there, but the nigrostriatal is where the movement is, and you're going to increase dopamine there and get more tics. So, whoops, I spelled course very wrong there, didn't I? Course, it's Swedish or something. Sorry. So 3 to 8 per thousand. So that's, that's a good chunk. 3 to 1 boys over girls. Interestingly, this is sort of interesting thing for etiology, a high familial and comorbidity with OCD. Those overlap a lot, OCD and Tourette's and tics, motor disorders. Higher dopamine neurotransmission. Well, that's they're more dopamine. Again, makes sense, right? More dopamine with the motor, and so they're going to have more dopamine activity. This nigrostriatal, talked about that already. And this one's pretty cool. The group A beta hemolytic streptococcal, pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. Cool term, pandas. So it's like the panda bears, which, by the way, are not actually bears. So people will get these motor tics after a strep throat, and then you get OCD after strep throat as well. So it's really, that's hence the neuropsychiatric, neuro with the motor and psychiatric with the OCD. So kind of interesting. It's a little bit hard to know what to do with that. I mean, if it comes like right after a strep throat, then you can make that diagnosis pretty good. But the problem is, everybody has strep throats, right? So it happens to most people. So you can't really say OCD is caused by strep throat, by beta hemolytic streptococcus. But it's kind of cool. I've seen there are cases where people have sort of onset of tics within a group, like a residential care or something like that. So a lot of the kids will start getting tics, and it can be treated with antibiotics. And the antibiotics will take care of the tics, which is pretty cool. Several years ago, and I wish I don't even know where to start looking for this now, because Google is like pre-Google even. But there is a story of a college campus, girls' dormitory, female dormitory, where a lot of the students in there started getting these tics. They started doing this, and didn't really know what it was. They had a psychologist, I think, who thought it was all just histrionics. They're all just kind of having, histrionic stuff like that. But I bet it wasn't. I would be suspicious that they had strep. They had group A beta hemolytic streptococcal infection going throughout the dorm, which they do, right? It's a closed environment and people get sick. But I don't know. If someone knows how to YouTube or find that, Google somehow. I don't even know where you would search. Girls' dormitory ticking or something. I don't know how you'd even search for that. But if you find it, that'd be cool. I'll give it to one of the younger, more adept at such internet searches to do. So differential diagnoses, ADHD and OCD, and of course it can occur with both of them. Okay, so there's quite a bit of overlap with those things. Some of the low dose alpha adrenergic, we don't talk about those too much, but they're agonists, alpha adrenergic, so adrenaline, norepinephrine, all those are adrenergic. Another problem, adrenaline and epinephrine are both the same. That's the same molecule. You can, if you know Latin, which we probably should have everybody take Latin, because if you're going into medicine, you should take Latin. So adrenaline, ad is on top of renal, adrenalin. Okay, so adrenalin is on top of a kidney. Epinephrine is on top of the nephron, kidney. So they're actually the same word. Adrenaline and epinephrine are actually saying on top of the kidney. So adrenergic is like adrenal gland. Yeah. Anyway, I feel almost so bad because it's like, why can't we get like one name? Being treated with Haldol, Pimozide, these are antipsychotics, so you're blocking the dopamine, right? You're blocking the dopamine on this on the nigrostriatal, and the second generation same kind of thing.
You can kind of say he has both, I guess, Tourette's and tic disorder.
I think if you have Tourette's, that you don't have both. I think Tourette's, yeah, I believe that's right. I have to, I don't know, I have to look that up. I believe that's correct, though. I'm not going to look it up right now. I believe that's correct. That if you have Tourette's, because Tourette's involves both tics and vocal tics. Tourette's is just more, they're more meaningful, is the thing about Tourette's. Actually, here we go, Tourette's. Both offensive. Make tics may wax and wane frequency. Yeah, I think. Okay, let me just look this up. Back here. Yeah, well, possible causes of the tics. Wilson's disease, that's a cool thing, never found it. Yeah. So Tourette's disorder must also be differentiated from persistent chronic motor and vocal tics, and more the presence of either motor or vocal, but not both. So yeah, Tourette's, I think the main difference with Tourette's, okay, is that the Tourette's has a little bit more of the activity of actually saying things as opposed to just ticking.
Okay, so tic disorder would fit him better.
I think so. Yeah, it's they overlap a lot. Frankly, it's one of those things where I'll confess here as your instructor that they both have tics. They both are vocal. Sometimes Tourette's is a little bit more, makes more like actual words, but I think they overlap a lot. So I'd probably give you okay if you have either one of those.
Perfect. Thank you.
You're welcome. Sorry about that. So one of the more important things we have in our society at the moment is autism spectrum disorder. So it's good to hear. Autism spectrum disorder, and it became a spectrum in the DSM-5. Initially described in 1948, by golly, 1948. So they used to have a Rett's disorder, a childhood integrated disorder, and Asperger's. Those all kind of got put by the wayside with the DSM-5. That's the problem, especially Asperger's. People sometimes wonder, well, how come we got rid of Asperger's? A lot of people got that diagnosis. The problem is, was against that inter-rater reliability. Where one person called Asperger's, other people called autism. Asperger's was roughly people with autism with good verbal skills. It's like, well, okay, what's good verbal skills? So it no longer exists. But that's pretty good. Good list again on in your book. Persistent deficits in social communication, social interaction across multiple contexts, and all the different things. Social emotional reciprocity, nonverbal communication, develop maintaining understanding relationships, and repetitive stereotype patterns of behavior. Various things have to be the same: inflexible adherence to routines, high restricted fixated interest, very abnormal, and hyper or hypoactivity and sensory input. They get really respond to things. Socks may bug them. They might not be able to handle socks. So it's let's see, we want to keep that. So those are the behaviors, and you can tell that with the spectrum disorder. Yeah, they have I'm trying to remember where I have all this in my thing. I don't. So with the spectrum, they now have with or without accompanying intellectual impairment, and with or without accompanying language impairment. So that covers the Asperger's and the intellectual disability part of it. So that's the criteria with or without intellectual impairment and language impairment. And you can have, of course, both. Yeah. It's well, let's kind of keep going a little bit. Range of behaviors, noticing symptoms, how well people will notice them. And I want to focus on this for a while. This one and the social things with autism, because it's those are really kind of the more concerning things. It's increasing in prevalence, and prevalence is how much is in the population, as opposed to incidence. That's how much arises at any particular time. So, why is it? Are we just recognizing it more, or the actual increased number of cases? I think most people are in agreement. It is increasing. It's increasing, and not just people are recognizing it more, because it's increasing a lot. Okay, so it's increasing a lot. It used to be like 1 in 10,000, I think, something, 1 in 1,000. Now it's about 1 in 80, I think, for both boys and girls. So that's a lot more. It's a couple orders of magnitude more. 41 boys and girls. Again, we don't really know why that is, but more boys. And here's some I keep in. This is just it's not necessarily out of the textbook, but I kind of like it. So this idea of TV, probably not. Is it just too much screen time? Yeah, probably not. But people argue that there's too much screen time and you're not getting that emotional reciprocity. Theory of mind, what that means is people have theories that other people have minds. It's kind of a funny term, I think, but and people with autism don't really have that. They have a harder time knowing other people have minds. This falls under the category we talked about quite a bit of course, it has a neurological component to it. What else would it be? But because they have a hard time reciprocity with emotions and with faces, and sure enough, the part of their brain, the fusiform facial area, is not as active. So again, not too surprising. And again, that emotional dysregulation, cerebellum with movements, so they'll have stereotype movements. That was cerebellum and the motor cortex. Language centers, of course. I mean, so this basically like gets the symptoms of autism and says, yep, they have brain areas. Who'd have thunk? A few things here. They have polymicrogyra, meaning they have more. And remember, the gyri is the nerve cells, and the cell size is the space between the nerve cells, sort of the fluid. So they have a lot more smaller gyri. It might be a failure of normal pruning. These are we don't know. Again, all these different ones are the complex between the temporal hippocampal, increased connectivity, impairment, in connectivity, self-awareness, consciousness, etc. So we can see this on imaging, right? Large different imaging techniques for the autism. This is I kind of keep in there again because there's no evidence for it. This is sort of a psychodynamic kind of a Freudian thing, but I keep it in there because it's like people think this. That's a common thing with mental illness, right? Because it always was thought with psychodynamics and with Freudian stuff, it's, somehow it's the relationship with the parents. It's like, well, then parents will feel guilty about that because, gosh, somehow raising my child, I made him have autism. It's like, no, it's not that. Problem parenthood can cause post-traumatic stress disorder and other things like that, but not schizophrenia or autism. Vaccinations, definitely not, but people still believe that. It's kind of a shame. We now get measles. How quaint. Measles was wiped out, but now it's coming back because of anti-vaxxers. I heard a study, or it wasn't a study, it's actually a report with the corona, that about 40% of the population will not get a vaccination for it. That's just like crazy, but okay, whatever. So anyway.
If you suspect somebody has autism, would you recommend doing like an MRI?
No. I mean, well, for this stuff?
Yeah.
Yeah. No, there's well, in our class, if your patient has autism, absolutely get an MRI. You can get whatever you want because insurance companies pay for it. It's not really necessary in most of these disorders, which is why insurance companies don't pay for it. Okay, because you can figure it out by interview, and there's not really any. Well, they're actually getting some exceptions to that now. There's very few diagnoses that you can get a differential diagnosis. You can tell if it's this one or that one. Hope we're getting some kind of. Yeah. Well, there you are. Thank you, Annalise. So we got teens who suddenly develop involuntary tics. Is this the one I was talking about? Holy smokes. See, I knew one of you people would figure it out. So, not sure if this is what you want. Maybe it might be. Like I say, it's a while back, and it may have been high school. Yeah, I'll check it out. I'm not going right now, but I'll check it out. Maybe it is. Thank you. Thank you. Even if it's not, I'll be able to take a look at it. So it's cool. Thank you. Where was I? Oh, autism. So, yeah, it's not like doing a brain scan, a MRI or whatever. We'll say it's autism spectrum disorder versus, I don't know, tic disorder. Okay, there's not like some kind of differential diagnosis there that would be worth getting a scan. That said, a little bit off topic here, but you can get PET scans. Okay, so it's a different type of imaging that can separate Alzheimer's from other forms of dementia, and that's good. Okay, that's cool because that will let you know if this is an appropriate treatment or not for Alzheimer's. It's a little bit superfluous in that we don't really have any treatment for Alzheimer's, but we'll get to that. That comes up later. Neurodevelopmental first, kids first, and we end with Alzheimer's. It kind of goes through the development. Another kind of quick thing that while you got me on the topic, there's gaining evidence for this, which is really cool. If this pans out, and I'm not going to put on my science hat, they're up there. But there's a few studies now that I'm aware of where when people are first started on an antidepressant, they get an EEG before they start. EEG, they get started on an antidepressant and get another EEG in about a week. Okay, and if the EEG makes certain changes, and I'd have to look up what those changes are, but they make certain changes, they'll respond to that antidepressant. If they don't make those changes, they switch over to something different. Okay, so that's pretty cool, because it usually takes about 8 weeks, right, for an antidepressant to kick in, to start working. So there's more studies, but the one I'm most familiar with is they start off with Celexa, which, if you remember correctly, or go back to the med sheet and you'll see. Start off with Celexa, which is serotonin. No problem, thank you. So it's a serotonin reuptake inhibitor. If it didn't do that change, they switched over to bupropion. So either one group, kept on Celexa, and the other group switched over to bupropion, double-blind, placebo-controlled, all that kind of stuff. And the ones that were switched over to bupropion responded, and the ones that continued on Celexa did not. So in bupropion, if you remember right, is not serotonergic at all. It's norepinephrine and dopamine. So it's a completely different mechanism. So if that pans out, right, if that works and continues to say, wow, this is great, this actually will save money and time and lives, that would be neat. That would be a good form, good use of EEG. So we'll see. Keep your fingers crossed. It'll be cool. Cell phones. There's actually a theoretical basis for cell phones, because the microwaves can screw up acetylcholine development. Again, sort of involved in memory, etc. They have like mice models where they zap mice with the microwaves that go through all our internet that we have everywhere, and they get a lot autistic mice. An hour time recognizing moods of other mice, which they can do. Actually, mice can figure that out, I guess. So that's interesting. I had a student, gosh, time goes by, right? Probably about 5 years ago now, who did her research methods course on cell phones and incidence of autism. And sure enough, as cell phone subscriptions went up, autism rates went up too. It's like a 0.97% correlation. So 97% correlation. So wow, that's pretty cool. That said, if one thing goes up and another thing goes up, even if they're completely unrelated, they'll have a correlation. So it might be absolutely spurious, but it was cool. It was an interesting thing, especially given that there's a theoretical basis to that. So maybe I should put on my science hat just to back to science. The way science works is you have a theory, right? You have a theory, and then you have evidence to support or not support that theory. You have to reject the null hypothesis or fail to reject the null hypothesis. I'm trying to get my wording correctly here. And that one rejected the null hypothesis. The null hypothesis was there would be no relationship in cell phone subscriptions and rates of autism, but it rejected the null hypothesis. But again, it may be unrelated completely, but still cool. Be a hell of a thing if it was, huh? Be a hell of a thing. It's like everybody has cell phones, so gee whiz. Treating, there's various treating ways to treat: modeling, operant conditioning, social integrating, flexible social rules, problem solving. This is the social way of treating autism. Augmented communication systems, so you have them point to symbols, letters on communication board or computer. From what I understand of those, you have to be real careful because you can lead them on, right? I mean, you can kind of point to where you think they want to point. And that's, so they're not really saying anything. And again, keep in mind, this is quite a spectrum. There's folks that are, pretty functional. They just can't, they're in school. They just don't interact very well. Frequently go into computers, frankly, it seems to me, which kind of makes sense. And there's others that are completely nonverbal, completely aren't able to stay in the community. Have never been toilet trained. That sort of level, even as adults. And there's actually, this is a good one to talk about all this stuff. There's parent training on how to work with folks with autism, community integration if you can. Again, that's really at that level. Things that will occur that will just they won't know what to do with it. females with autism, as they hit adolescence, they'll start menstruating. And it just really distresses them because they have no way of really knowing what this is. Okay, so it's one of the more psychosocial things with autism that is really part of the treatment system. So, teach them how to interact in the community. That's one thing you can do. But again, it sort of depends on the severity of it. Animal therapy, there's some evidence that works. They get along with horses and dogs, in particular horses, better than they do people. So that's nice. Sensory stimulation, you decrease sensory stimulation, because it irritates them. Yeah.
It can actually go both ways with animal therapy.
Oh yeah.
When I was working at Westmont, I was there for a couple years, and we had a client there who had autism, and we used to allow him to have a therapeutic animal to help.
Mm-hmm.
But he started harming that animal.
Oh dear.
So we had to change up our rules and regulations and stuff like that. So it can go either way.
Yeah. Yeah. And well, I'm not surprised at that. I mean, I never thought of that, but all therapies, nothing works for everybody, right? So, and I'd have to look up I'd have to do a PubMed search on that to see what the rate of improvement is for animal therapy. Put on science hat again. So, clinical hat, if it works, that's cool. Science hat, how are you going to have a placebo control for animal therapy? So, okay, you can have people without animals and people with animals. Okay, but you're not getting double blind on that. You're kind of going to know who has the horse around. Yes, it's going to be hard to have like a fake horse, placebo horse. It looks like a horse, but it actually is not a horse. So I would bet that, and I'd have to look into this more intensely because I don't know offhand. I would bet that there's the studies on that are not the best, okay? Because again, they're good studies, I'm sure, and they'll have these limitations because you're not going to have a placebo horse. That's a funny thing to say, the placebo horses. Oxytocin, you can. Okay, oxytocin. I know there's some studies with that too. Not enough that it's like, well, let's use oxytocin for autism spectrum disorder, but oxytocin does is, if you remember right, it's the cuddle hormone where people get more connection, they'll feel more in tune with each other. I know there's studies with autism of giving them oxytocin, but again, it's not really well known. There's actually I should throw some more things in there. Need to take the summer off and update all my PowerPoints. There's some cool stuff coming out with autism. Let's go back to this one. Let's keep it. Doesn't matter. It doesn't matter. Where they look at the bowel flora, okay, the bacteria in the bowel, and they have really different bowel flora. This is very disturbed, completely different. And this was picked up because they noticed that people with autism are often constipated. They're often constipated, and as well, maybe they just are constipated because they don't know how to go to the bathroom because they have autism. But no, turns out that their bowel flora is very different, and there's dozens of different kinds of bacteria that live in your bowel, and I'm not going to be able to list them all off, but it's pretty cool. It's really interesting. Again, sort of some smaller studies. Yes, I should have a whole lecture now on autism. I've learned a lot more about it these days. There's studies where they actually do fecal transplants with autism. What that is, it's kind of gross, but it's cool. You basically you clean out the bowel, like as if you have a prep for a colonoscopy or something. You get them clean out all the feces from the bowel, and you get somebody else's feces that have normal flora. So the bacteria is not abnormal; it's normal bacterial. You kind of dilute it, and then you squirt it up into the large intestine. It's kind of like ew, but again, these are smaller studies. It's kind of, I don't know if I doubt if they're placebo controlled. I'd have to look them up. I just saw some smaller studies, but by report, some of the folks with autism get better. I've heard also that people use probiotics or macrobiotics, where you take doses of lactobacilli and that sort of thing. And some of those also have shown some support. Maybe what we can do here, actually, it's 10:38. Let's just get through this talk, and we'll pop onto PubMed and see, kind of get updates on some of this stuff for you guys, because it's pretty interesting. Again, given how much it's a problem, and how much autism is a problem, these are very important considerations. Another sort of well, let's see. I'm going to wait on that. Another issue with autism that we alluded to on Tuesday is the transition from the child and adolescent system to the adult system, because the adult system frequently are not set up to work with folks with autism. They're set up for people with schizophrenia, people with bipolar disorder, major depression, that sort of thing. And autism doesn't always have intellectual disability. And even if it does, and I'd be interested in some of your all's perspective on that. If it does have an intellectual disability, it's not the same as other people's intellectual disability, okay? Because it's a disorder in and of itself. So it's a rough deal. It's a rough deal. I know in Montana we're having trouble, well, frankly, because we closed the Montana Developmental Center, or actually made it just much, much smaller. And people with autism sometimes can't be treated in the community because, they're hitting people and hitting animals and stuff like that. So they get sent to the state hospital, which is totally not set up for people with autism. It's for, short-term medication for people with psychoses and suicide and that sort of thing. So it's system-wide, this is a problem. How to best care for folks with autism and spectrum disorder. And so I think a few of you here are also going into social work. Here you go. Here you go. This would be a great social work thing to do, public health / social work thing to do. Yeah, so yeah, really targeted medication. Your textbook throws out a couple of things. There's not really any particular medication. Okay, I mean, you can target symptoms. If they're aggressive, you can do stuff with that. But you have to be careful you don't end up like Brandy. Okay, they get just all these different medications and they get just kind of sedated. Another system thing that occurs is when they're in a facility, they're in a very structured facility, they do better because it's structured. Okay, so they get to the facility, well, they're doing pretty good. They get sent out in the community. Well, it's not nearly as structured, and they don't do as well. So they go back to the more structured, higher level of care, do well because it's structured, and and around it goes. So, yeah, this is a big deal. We're not doing well, and in many ways, but in particular with this one. Any other questions on autism? I know people get pretty. It's a pretty interesting thing.
No, I think you're good.
Okay, thank you. People usually often will have questions on it because it's just such a prominent thing these days. So intellectual disability, this is again, this is sort of old-fashioned. This just shows how we used to diagnose it. So it used to be just IQ, with 100 being normal by definition, and mental retardation was called 70 and below. Intellectual disability is what it's termed now. This came DSM-5, intellectual disabilities, DSM-5, which is a good thing that is called intellectual disability. Mental retardation, it became derogatory, right? People started using it derogatorily, but it meant that you're going at a certain developmental level and then you got retarded and slowed down. Well, no, that didn't happen because they're always disabled. Developmental delay is the other one that was kind of put in instead of mental retardation. Means you delayed, but you catch up. Well, no. So intellectual disability was like, well, of course that's what it's called. Now it's not really so much IQ. It's these things. Page 96 lists these off pretty good. And this is how you diagnose it now. IQ is not what you do. So if you have people who are still using IQ, it's not true. So past mental retardation defined by basis of IQ, but intellectual disability, there's no longer an arbitrary reliance on IQ, which is the kind of the main thing. Used to classify as mild, moderate, severe, or profound. It failed to take into account individuals' adaptive functioning, et cetera, et cetera. So now it has these different deficits. The conceptual, academic, which is roughly equivalent to IQ. This is adaptation. So competence in memory, language, reading, writing, math, reasoning, acquisition of practical knowledge, problem solving, judgment in novel situations. Social involves awareness of others' thoughts, feelings, experiences, empathy, interpersonal communication. And practical, learning and self-management across life settings, personal care, job responsibilities, etc. So it's now looked at those domains as opposed to IQ, which again makes a lot more sense. It's probably a little harder to diagnose because IQ, you just give a test and boom, you have an IQ. This one it's harder, but it's more, well, it's better, it's more accurate.
I do have a question. You may have already answered it. So I had to step away for a second, but it was just going back to the autism thing. So I've heard in the past that if you catch it early enough, that there are certain treatments that you can do to help.
Yeah.
Like, because I work at Shodair, and we're not really super well equipped for children with autism, and there are things that we can do, but they need specialized care in order to help treat. And I don't know if that's even the right word, treat. But what are some of those things that you can do early on, and why do you have to catch it early on?
It's called applied behavioral analysis. Applied behavioral analysis is what you're referring to. Yeah, I really need to redo this talk here. Cancel class, I need to redo this entire talk. Applied behavioral analysis is basically operant conditioning. So you do this, you get a reward. You do that, you get a reward. So positive reinforcement. It's operant conditioning, and you have to do it young because the brains are developing. Okay, so if you catch them like 2 to 3, because you can diagnose it about 2 to 3 years old, and if you catch them, then you can start doing this operant conditioning, and where the brain forms from that is less autistic. Okay, so you can treat it young. So yeah, that's why it's pretty intense. ABA is very intense. It's I think you have to have something to the extent of, it's like every day, a few hours every day, because it's really fairly intensive. But if you catch it early on,
specific programs, or is it something that you can do on your own if you have a child that is autistic?
No, there's it's called a certified applied behavioral analysis. That's what it's called. Yeah, let's look up a lot of this stuff. Let's get through the intellectual disability, but we'll look up applied behavioral analysis and autism, because you get trained in it. It's a certain training. You get like a degree. You get a certification for it. There's folks in town that do this. There's it's kind of a popular thing. So applied behavioral analysis. Okay. So yeah, we'll look this up.
Okay.
Kind of do the intellectual disability, and then look up all the stuff with autism. So we've got ABA. We have bowel flora and animal therapy, huh? And I'll just keep the abstracts is what I'll do. I'll keep the abstracts and add this to my talk, probably after we're done here today, as a matter of fact, because it's interesting again that because we're getting so much with autism that we have to get on top of it. The ABA is not indicated. It's not indicated for people. I think it's like over, I want to say 12, but it's maybe it's better than younger. So, and it's indicated for the younger people, but folks want to have it for older people with autism, adults, and it's never been shown to work. They want ABA for things that aren't autism, and there's no data on that whatsoever. And so, but for applied behavioral analysis for young people with autism, their prognosis is a lot better. And that's why, because the brains are developing. You get to get in all the neural connections. Good questions. Yeah, we'll pursue this more. Yeah, I've heard Shodair has you kind of illustrate my point, right? That Shodair, which is a great hospital, right? It's an absolutely wonderful hospital. Autism is just something that it's not set up to do. It's a completely different thing. It'd be like having Shodair treat seizures. It's like, well, it's a brain, yeah. So it's a similar organ. Maybe you can treat strokes too or whatever, but it's just a different thing.
Yeah, that's why I was trying to get them involved in the autism conference last year, but ended up having to get canceled because of COVID. But
yeah. So yeah, maybe we should. I wonder have because everything's virtual now, right? Everything's virtual, so maybe we can have a virtual conference on autism. Be kind of a pain to do that, but I have no idea how to do that. But it would be cool. Lots of things cause it. Intellectual disability. Downs is the most common. Fragile X, but there's a lot. What we got here? You'd be very interested in Taylor? Yeah. Well, it's yeah, I always have to be careful because I just give myself more work. So maybe I'll have you join the psych club, because one of the main things that the psychology club did was the one NAMI walks, which that's just people are signing up for that. If you haven't, please do. And 2 was the autism conference, because it's a fair amount of work. But I mean, it can't be that hard. People do this, right? So then do the online. Yeah, let's think about that. We'll think about that. I'm going to form the team, psych club team today. So I'll send you an invite. Because it's just yeah. We'll get to that when we start looking into some of the other things with autism. But it was pretty cool. Kind of, we're stuck on autism here, which is fine. But the conferences were really cool. And we had first year we had like 25. Next year had about 50. And the year and a half ago now we had like 150 people. We had in the student center. It was packed. We had food. We had keynote addresses. We had it was cool. And it's like it was the only it's the only conference on autism in the state of Montana. Let's. I'm going to. Let's see. Now we'll get to this. Because I have another talk. I want to. It's only like 6 slides to talk about how to take care of people with intellectual disability and how they're be kind of different. Because remember, they may or may not. They can have psychiatric disorders. They can also have a bipolar disorder. They can have depression. It's a little bit harder to diagnose because oftentimes they're not able to articulate well, and hence they're intellectually disabled. They may not present with the same type of symptoms, again just due to the intellectual disability, etc. Other medical problems. People will have aggression. Okay, they'll have intellectual disability and aggression. I had a case where a fellow who lived in an institution group home and suddenly was generally not an aggressive person, but suddenly became really aggressive and hitting and kicking and screaming and all that kind of stuff. Got admitted, and it turned out he was constipated, like way constipated, hadn't pooped in like 2 weeks. I think it upset the best of us, right? So I basically made him poop, and he pooped a lot. It was quite something for the people to kind of get to, but he stopped being aggressive, and that was all we had to do, was get him to poop. Enuresis and encoparesis. Enuresis is the bedwetting, usually boys more than girls. Encoparesis is having poop basically slip out of your backside. Boys forget to go because they don't go to potty, and they get the colon stretched out full of stool. So that's what you have to decompress the bowel. Enemas, fish oil, that kind of stuff. So you decompress the bowel, that gets the more normal peristalsis again, squeezes the poop out, and you're good. This is usually self-limiting. It's a behavior of endocrinology, which is kind of a cool thing, that the bladder stretching will set off a sort of endocrine systems that your brain picks up, and you wake up and you go potty. Bells will help that develop. You have a little bit of wetness, the bell goes off, the kid wakes up and goes potty. So you start getting that condition reflex there. Decreased fluid after dinner, so so they can't pee, and have them make less pee with DDAVP. Child abuse, again, this is we should throw in the ACE study. We talk about that, the adverse childhood experiences. It's really interesting how you can. It's quantitative. It's quantitative. You can list how many adverse experiences children have, and that correlates with quantitatively with how much trouble they have as an adult. And it's not just mood disorders and anxiety disorders and post-traumatic stress disorder. It's also they have more cancer, more heart disease, more obesity, all that sort of stuff. And it's separated. It's not just because they smoke more. They do, but it's not just that. It separates out the trauma itself does. And can you get intergenerational abuse? Yeah, especially sexual abuse, from what I understand of the literature. That if you're abused as a child, you're more likely to abuse your children, and it gets an ongoing culture of abuse. Right, there are actually some articles that don't really support the intergenerational physical abuse. There was one big study that I saw in Science that they looked at. It was kind of a cool study. They looked at old Child Protective Service calls from like the 70s and 80s, and then followed up and see if those people, as when they're adults, if they abused their children. And in that study, they did not. They did not physically abuse their children. If they were sexually abused, they sexually abused their children. So that got passed along, but the other one didn't. That said, other studies say no, that it does get passed along. My science hat has to go on here again. Okay. And so this is a neurobehavioral disorder associated with prenatal alcohol exposure. And the acronym is not very good. NEPAPM. It doesn't work. So basically, more than minimal exposure. And what is minimal exposure? Good question. This is, my stance on that, because I'll have students ask me, well, how much wine can you drink? Why would you want to? I mean, if you have to have a glass of wine for 9 months while carrying a baby, you might think about having a problem there. Yeah. So again, they have impaired neurocognitive functioning, executive functioning, learning, etc. Got a comment here. Oh, okay. The dopamine nightmare before we go. Yeah. I don't know if I want to go up to my board. I guess sort of awkward. Yeah, we can. Let's see. We got Okay, so it's coming up. We're good. Yeah, let me get. I'm judging myself here. 10:55. All right. So, what should we do to prevent this? Should you be able to take moms who are drinking too much and sort of lock them away so they can't drink? Yeah, it's kind of a difficult call, but I don't know. Could argue it, really. You could argue that. And other drugs in utero, methamphetamine is just messed up. There's not. It's interesting because there's not a lot of sort of clear descriptions of meth babies, but boy, they're hard. They're hard to treat, from what I understand. Again, my partner sees a lot of this, folks. Because they don't really respond to antipsychotics or anything, because it's not really what's going on. So yeah, methamphetamine in utero is really that's not good. So, a few slides on intellectual disabilities and mental illness. Things to keep in mind. Okay, they are more likely to have a mental illness, but not always, right? So they might just have intellectual disability, and that's what it is. Systems. It's really a problem with systems, and this is like one of the main things we have to think about. A lot of staff turnover. So these people are fairly rigid, right? They kind of like routine. They like counting on stuff, and now you're having staff turnover, and it'll upset them there. Where they're staying, they might go from one place to another. Again, other providers, so not just the staff of the group home, but psychotherapists and physicians, etc. And is there potential for abuse? Yes, there is. People will, some people just aren't nice people. they'll abuse because they may be nonverbal, right? So they can't say so and so did this to me. So so and so might do things to them because of that.
You see a lot of this at Westmont, the place that I work at.
What do you see?
A lot of abuse, and all kinds of abuse, because they're disabled adults, and they have a lot of them are nonverbal, and a lot of them are like paraplegics, blind, deaf type of people, and we've had several cases over like just within the last year, just a high amount of abuse.
Yeah. Did they get reported to Adult Protective Services?
Oh yeah. A lot of it just doesn't make the media because it's not really anybody else's business.
Right.
I mean, that one that did make the news, that was a pretty big one, but we've had several like little cases bruises showing up on clients and stuff like that. A lot of that doesn't make the media because it goes against HIPAA in a way. So
right, yeah. I mean, yeah. I'm not aware of a particular place, but I'm aware of these abuses that happen. People. It actually gets to. This is where you need to. This is where we really need better training. We really do. So the aggression, agitation, these are some of the presentations that they'll have. And they might want to go to the hospital. Yeah, let's do this one. I want to make sure we kind of do some other stuff on autism. But in the dopamine nightmare, I'll do that one again too. So because they have this different presentation, they might just repeat things. I want to go to the store. 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 That's part of the symptom. Now, when someone does that, it gets irritating. But as treatment providers, you have to kind of say, this is what's wrong. Okay, and that's okay. Well, we can't go to the store. It sounds like you want to go to the store. You want to validate. Okay, well, it sounds like you're pretty, you really want to go to the store. And maybe we can, how can we do to get you to the store? And what can we do for that? And by doing that, you can really help them. And this book is really cool. I already showed you this one here. This skill system for the cognitive challenged clients. It's really cool. I just got turned on to this like the other day. Sort of one of many things to do. That'd be a kind of a cool class to have, right? A cool certification or whatever for students to have this something on that. And they might say yes or no to questions because they just think you should say yes or no. Okay. They know what you're supposed to talk about when you go see a therapist or a doctor. You're supposed to say you're suicidal and that you hear voices. That's what you're supposed to say. If you ask them if they have this symptom, yes. Have that symptom, yes. Have that symptom, yes. But it's not. They don't really have that symptom. But they think you're supposed to say yes. So they're different to treat, and you have to keep that in mind. Their intellectual disability, when you're taking care of them. I know people get really mad at clients because they keep saying I want to go swimming or something, and then they don't have the ability to sort of meet them and try to figure out what that need is, and validate them. Yeah. So you may miss. So these are things that you just have to be able to kind of know is out there. Again, given their intellectual disability, they might already be withdrawn. So withdrawing more might be missed. You may not notice that they're withdrawing more. And because they're the sensory impairments, they may not be able to say they're anxious. They might say things like, I miss my brother. I miss my brother. I miss my brother. And that might mean they're sad. Okay, there might be something like that, or they might say, I'm really, whatever it might be. It might be something that's sort of not related to what they're trying to say, but you have to sort of be able to know what that is. All right, well, let's do this.
So would you say that Jacob has an intellectual disability when he's like constantly asking about himself? Is he constantly in trouble?
No.
Or
that certainly wasn't part of my thinking when I made the case. How about that? If you can, I'm going to see. I'm trying to figure out which is the best place to do here. If you can make a good argument for that, that's great. If you make a good argument for that, I'll say, okay, yes, that's good. So I'm trying to find a place. Okay, let's do this because I'm still recording. Hold on, puppy dog. Put it here. Yeah, that's the best place. I'm gonna let my dog in. Come on, you're getting kind of popular with all my students. You are. So I want to do the dopamine nightmare thing here because I think it's that's helpful for students to know. So get my little brain, little cerebellum, and the eyes are out here. Now the dopamine nightmare will have substantia nigra, so it'll be black. So there's the basal ganglia about there. Substantia nigra is about there, and it'll innervate that. Okay, so with the tics, there's too much dopamine. How's that? That's really bad writing. It's just like, that's really bad writing. So with ADHD, what color should that be? How about green? It's in the prefrontal cortex where there's decreased dopamine and norepi. Okay, so if you're giving something, color do I want now? I'll go to, how about purple? So
what
if you're
did you
giving
say was the
something,
decrease in dopamine and norepinephrine?
norepinephrine in the prefrontal cortex, yeah. Okay, remember the concentration, attention, okay, attending to something takes energy. Okay, it takes norepinephrine and to a lesser extent dopamine in the prefrontal cortex. So in order to treat ADHD, you want to give something to increase those because they're decreased, so you want to increase those. But by doing that, you're now increasing those too, and you're getting tics. Okay, you get even worse tics. And I mean, one of the side effects of the stimulants is you get kind of muscle tics. So that's what makes that worse. Conversely, if you decrease dopamine by using antipsychotics, you'll have a chance, you also will decrease it here, and ADHD might get worse. Luckily, the norepinephrine will still be modulated with the stimulant, so that you might be able to kind of pull it off with that. But that's the dopamine nightmare. Okay, got low dopamine one place, high dopamine another. So do you block it in one place, which makes the lower even lower, or you increase it, which makes the higher even higher. Okay.
So
Madeline,
if you have too much dopamine, do you want to use a antipsychotic?
Well, one of the treatments for the tics is antipsychotics. Yeah.
Okay.
Yeah. Good though. You got that put together. Good for you. It's coming together, eh? Yeah, it is. It's kind of fun when it comes together. So does that work? You'd be able to speak more about Madeline, does that help? You can just put the chat room thing in there.
I have a few questions, but I can ask you in your office hours because it has to do with the clinical assessment sheet.
Oh, okay. Well, let's do this then. Let me, I need to get back to, no, I don't need to do anything with that. Good. Thank you. Good. Go to here. Let's stop sharing. And I'm going to keep recording this. You're welcome. All right, so now we're going to go back to here. Share. PubMed. All right, so you all should be seeing my screen, PubMed. And animal therapy. We have a Word document handy here. Let's see what we get. Cannabidiol, a suggested candidate for treatment of autism spectrum disorder. Of course. Cannabidiol, that treats everything, doesn't it? Let's just see what it has. Yeah, it drives me crazy. Yeah, cannabidiol.
There's a couple of my clients at Westmont who use CBD and cannabis in pill form and stuff to help with their disabilities, and it does help. With seizures mainly.
Seizures. Yep, there are data for seizures. I've heard actually people are giving their medical marijuana to people with autism. All right, here we go. Quite assist, this one here. People grooving on this? Limited engagement activities, multiple baseline studies, that's good. Multiple baseline is good. 7 children, not very many, but that's okay. 4 to 8, including a horse and occupational therapy. They did show improvements in engagement, so small study, but not a bad design. It might be valuable. So that's not bad. And here's a nice systematic literature review. So inclusion of animals in therapeutic activities, animal assisted intervention for autism spectrum disorder. Does empirical research on it, blah, blah, blah. Presentation of AAI was highly variable. Outcomes include improvements for multiple areas of functioning, social interaction, communication, etc. Despite anonymously positive outcomes, most studies were limited by many methodological weaknesses, which they often are. There is proof of concept for it, but more rigorous research needs to be done. So yeah, there you go. That's not bad. Interesting. 2013, so that's not too bad. So how about autism spectrum disorder applied? There we are. Which one? 2013. This one's 2016. And yeah, you can be a certified applied behavioral analysis therapist. This is a thing. Come on. Hello. There you are. And nope. That looks like a book, I guess, huh? Here we are. Here's a literature review on it. Yeah. So paper reviews, intervention processes, only 4 papers report the role of ABA principles at home, et cetera, et cetera. So okay, well, that one's not good. But that's the idea. If you look up ABA on its own, there's people are pretty into it. No, there's a lot of stuff here, huh? So breastfeeding status, risk autism. Look at that. There's just more and more and more stuff. The bottom line is we don't know what's going on with it. Okay, that's we just don't know. Okay. An open label study of 2-year follow-up suggests that microbiota transplant therapy is relatively safe. Wow, well, kind of cool. Relatively safe and effective in significantly reducing gastrointestinal disorders and autism spectrum symptoms. Wow. There you go. That's really cool.
Wait, so fecal transplant can reduce autism spectrum disorder?
That's what it looks like.
That's bizarre.
Yeah, bizarre. So yeah, so here's, yeah, that's what that study said. I mean, this is just, I'm just jumping on PubMed here, right? So I could do a lot more. Yeah, so here's the heterogeneous gut-brain link. There's a lot of stuff coming out between the gut flora and psychiatric illness, like a lot of stuff coming out. It's really interesting. Diet modulations, prebiotics, probiotics, antiflora, fecal transplantation, activated charcoal. Yeah. Let's see. Isn't that cool? This is so interesting. I want to see if they have related articles. They sometimes will have related articles. Nope, not this time. So yeah, I mean that would be a heck of a thing, huh? I mean, it sounds like they need more study with it, but that's looks like it's a thing. Yeah. Yeah, there's a lot of stuff on there. Yeah, here's another one, open label study from 2017. So it's pretty recent stuff. Oh, Amber Moon. Let's see. David, neat and gross. Yes, definitely. Annalise seconded that, so you both should be in the Psych Club. A cool episode of Science V's about gut bacteria. Huh, okay. Amber Moon, we'll have to check that out. Yeah, it's really interesting. There's more and more stuff coming out. So here's gut bio. Where's the one in mood disorders? Here we are. And so this is, I mean, just, it's crappy research, a lot of it. Okay. Yeah, yeah. So anyway, this is a thing. People are looking at gut microbiota and fecal transplant was what I tend to term it. But cool. Well, all right. That's really interesting. Let's go back to here. I'll stop sharing the screen.